was reported by several of our AIOS members, and several of the steps were taken in response to that by the All India Ophthalmological Society. TASS is a unique syndrome because there are so many things which go into the eye and you cannot predict which thing is actually causing the intraocular reactions. So we are just waiting for the audio visual. Koi nahi hai. Audio visual people to come here. And more importantly, I think in the immediate post-operative period, TASS has to be differentiated from endophthalmitis. So Anaga, can you tell your experience with the outbreak of the cases that you had recently?
Yes, ma'am. Actually, this began in August, where we had the first 5 cases, and later on when we tried to introspect on our own, thinking whether there was any other issue regarding cleaning protocols or sterilization protocols. And then as we went on, we changed the viscoelastics, the BSS, but still the problem persisted, and that is why as we went on investigating, we finally found that there were some patients of the same lens that were showing the problem. It was typically a fibrinous reaction with hypopion and having poor vision immediate post-op. Is that on कीजिए?
ये लैपटॉप नहीं लगेगा तो कोई लगाएगा तो लगेगा इस पे ये HDMI है सर बट मेरे को HDMI का पोर्ट नहीं मिला मतलब वो चाहिए उसके लिए किसी की ड्यूटी तो होगी भाग कैसे गए लोग I will just give an overview of TASS because this session was meant for an interaction between the delegates and at the level of the All India Ophthalmological Society. So it is uncommon and the cause is mainly the toxic substance which is introduced into the eye. It usually presents 12 to 48 hours post-operatively. Late presentation has also been reported. And there are several ways by which you can address it. It could be a localized endophthalmitis, steroid post-op endophthalmitis, toxic lens syndrome, sterile hypopion, etc. Now, the reported incidence is more than 1 in 1,000 after cataract surgery. And from India, we have only one study which has reported the incidence to be 0.22%. Most common surgery is phacoemulsification, but important thing is that it can also occur after penetrating keratoplasty, vitrectomy, DSEC triple, DALC, phakic intraocular lenses, etc. And there have been major outbreaks of TASS even in other countries. And if you see, the numbers have been huge in the other countries. And it has been the etiology, most cases is not identified. And sometimes they do pinpoint it could be because of heavy metals in the production of the intraocular lenses, or in the Indian study which happened in 2009, it was unidentified, or related to the OVDs. So, because so many things they go inside the eye like solutions and IOLs, OVDs, BSS, antibiotics, anesthetics, intraocular dyes, ointments post-op some people give, even when you give intravitreal injections, preservative related to the drops, powdered gloves, reusing cannula, inadequate flushing, enzymatic detergents, etc. All these things can lead to a reaction in the anterior chamber. Systemic causes are also there like uncontrolled type 2 diabetes, systemic hypertension, hyperlipidemia, systemic inflammation, and these do have a role to play. In one study, 53% were hypertensive, 20% were diabetics. So in the last 25 years, there has been an increase because we are now doing closed chamber surgeries. There have been advances in technology. We use machines, we use cassettes, we use tubings. There are new substances and medications. In 2007, the American Society for Cataract and Refractive Surgery created a TASS task force. And this was done because there was an outbreak of TASS at that time in 2007. And so a TASS registry was created which has reported 1,000+ cases. And the most common risk factor is inadequate instrument cleaning and sterilization. So if the flushing of the handpieces is not adequate, or the cannulas are being reused inadequate, or no manual cleaning of instruments is there, use of enzymatic detergents, ultrasound baths, etc., these can lead to TASS. It has been related to the cellular toxicity, which is difficult to identify in any chemical agent that you are using to clean your instruments. Free radicals, which are delivered because of the several intracameral agents, and also because of ultrasound oscillation that happens with the phaco machine, and breakdown of the blood aqueous barrier, which can occur because of any cause. So basically what would happen if you look at the clinical features is that there will be blurred vision since first post-op day. Most cases are 20 by 20 to 20 by 50. In severe cases, you can have counting fingers and PL+. Pain is not prominent. Patients generally have foreign body sensation, and signs are out of proportions to the symptoms. So you can have some amount of uveitis. The corneal edema is limbus to limbus. Secondary glaucoma can be there. Iris ischemia can be there. Then people have even reported posterior segment involvement in the form of CME and vitreous opacities. Now just to show some of the cases, only inflammatory membrane is there, features of iris atrophy are there, fibrinous reaction is there. So these are also telltale signs like iris atrophy to tell you that TASS has occurred. It has to be differentiated from endophthalmitis and from uveitis, which may be there, which may also occur post-operatively. And generally the diagnosis is clinical. Cultures of anterior segment TAP can be done, but they are not mandatory for the diagnosis. And PCR is useful in differentiating it from endophthalmitis, but you don't need to do it for TASS. So these are just some differentiating features. The TASS tends to occur immediately, endoph a little later. Pain is moderate to severe in endophthalmitis, none to mild discomfort in TASS. Intraocular pressure is significantly increased in TASS, and corneal edema is limbus to limbus. I think that is the most important thing. Fibrin is usually not present in TASS, and vitritis is mild to moderate, and hypopyon is rare as opposed to endophthalmitis, where it may be common. Important thing is that there can be endothelial cell loss, epithelial downgrowth, secondary glaucoma subsequent to trabeculitis, peripheral anterior synechiae, and Uritz-Zevelia syndrome. And management, most cases do resolve with the medical treatment and observation. You can give topical steroids, 1% prednisolone every 1 to 2 hours initially. With increasing severity, one can give steroids, even subconjunctival injection. People have given, oral steroids can be given. And I really don't know, somebody has to tell us whether intravitreal triamcinolone or dexamethasone works or not. Then topical NSAIDs are given, and IOP management has to be done. In very refractory cases, even intracameral injection of recombinant tissue plasminogen has been used for complete clearance of fibrin reaction, which is occurring in 80% of the cases. And this is the resolution of TASS which occurs with the medical management. Now, surgery would depend on the severity and etiology, and in 30% of the cases, surgical intervention can be done. If there is an endothelial decompensation, we do DSEC, and we've got a series of DSEC following TASS almost in 20 plus cases now, and it is important that there should be a gap of at least 3 to 6 months between TASS and between this endothelial keratoplasty, because DSEC or endothelial keratoplasty can also cause TASS. And the prognosis of DSEC in cases of TASS is not as good as it is for DSEC for other indications. Refractory glaucoma cases, filtering surgery may have to be done. Now this is just to show our outcomes of DSEC and TASS post-operatively. Visual acuity was 618 to 69, and we did in all of the cases 6 months following TASS we did the DSEC surgery. Prevention is very important, so one should be aware about TASS. Prompt diagnosis and treatment is required. Reporting clusters and investigating appropriately is what is required, and maintaining the standards of ophthalmics, instrument cleaning and sterilization as per the recommendations by various task force set up in collaboration with ASCRS, AO, and the daycare society, or the daycare society from the American Academy of Ophthalmology. They have given several of the recommendations which should be followed. Now, these are the task force committees by the world over societies. All of them, in fact, have some form of task force committee in some way or the other, where these can be reported. And that is all about TASS, the clinical presentations and the outcomes. Now, in the advent of the recent outbreak of TASS, I would request Dr. Anaga Haroor to present her case series and her experiences with the recent outbreak of TASS. I would also request Dr. Lalit Verma, the president of AIOS, to please come on the chair, sir.
Very good evening to all of you. At the outset, I would like to thank Professor Dr. NAMRATA Sharma ma'am for giving me an opportunity to express my journey and what has happened in the last few months. So this was the picture what we saw a lot in the last few months, and this had got us extremely frustrated and harrowed, and absolutely it was a nightmare. Majority of our patients, we had almost around 77 patients who experienced TASS, which was over the last 4 months. Most of these patients had the first post-op day having either finger counting 2 feet and vision less than 660. Cornea showed mild corneal edema. There was a membrane in the pupillary area with hypopyon. Most of the patients had intraocular pressure which was high. Some of them also had normal, and some of them, we used to dilate them immediately to also look at the posterior segment, and majority of them also had a grade 2 to 3 vitritis. Fortunately, none of them had a significant posterior segment involvement requiring any kind of intravitreal treatment similar to kind of an endophthalmitis like picture. All these patients were treated medically with topical early steroids, atropine, and even oral steroids in many of them. These were also many one-eyed patients, so it was extremely disturbing for us when even after an excellent, uneventful surgery, all these patients came back to us with poor vision post-op. In fact, they used to compare it with the other eye where we had done just a few months ago, and they used to say, what happened to this eye? When during surgery there was absolutely no issue. We followed up these patients very rigorously even after we started the treatment, so as to see whether they were really recovering completely or not. Some of them had just this streak hypopyon and a mild corneal edema, and all these patients responded well. The good thing was that all of them responded well to topical and systemic steroids. Some of them took almost a week to 2 to 3 weeks. In fact, now some of these patients are coming back with CME and post-operative uveitis. Just 2-3 days back, a patient who had operated in August, he was a one-eyed patient, came back with CME. So the problem is not totally gone. It's not that at the end of 15 days everything is over. So just that we need to be very vigilant about these patients. So what we did when we experienced this patient is, first thing is, we thought maybe something was wrong with our cleaning protocols or sterilization protocols. So we checked out all the irrigating fluids, the viscoelastics, whatever we were using, we changed them. We saw our sterilization protocols, the instrument cleaning protocols, all the hollow instruments, the cannulae, we made sure that all this was in place. In fact, just to be on the safer side, we ordered 10 new tips, 10 new bimanuals, so as to not use the older instruments at all. In fact, in spite of doing all this, when the task continued, we almost were to the verge of stopping the OT to take stock of the situation, and a complete audit was done, and we thought we would only start few cases one by one just to see whether there is any problem. The final clue was, we had one more center which we recently started, and there everything was new, including the autoclave. And there we had 3 cases. 2 had hypopyon, which belonged to a particular IOL. And then when we noticed that everything else was the same, we went back to our main center records to see that all those patients in whom we had operated and which had developed TASS, had the same lens was used. But another part of the story also is, like, for example, if we had used 60 lenses, of the same company in a month. Not all 60 of them developed, it was only 1/3 or 2/3 of them. So then we also discussed with colleagues, and then we found that all of them also were facing the same problem. In fact, when I spoke to the company representative saying that we are noticing some inflammation like this, he mentioned that somebody else also had a similar problem, and then it continued when we discussed with others. So for the last 1 month now, we have stopped using the lens, and there is no TASS noted ever since. So these were the details. August we had 5 cases, September 20 cases, October 18 cases, November 22 cases, December 13 cases, and at the end of this, we stopped using the lenses from 12th December onwards. So it's just that our experience was totally harrowing, and I just feel that whatever we did after that to increase awareness, holding 2 safety webinars on behalf of Maharashtra Ophthalmological Society, and I appreciate the efforts of the All India leadership, Dr. Lalit Verma sir and NAMRATA madam, for actively pursuing this and taking part and helping all of us being aware and taking the necessary precautions. Thank you so much, ma'am, for the opportunity.
Thank you, Anaga. Thank you for your experience on TASS. Dr. Lalit Verma sir, would you like to comment on what AIOS is doing for TASS?
Thank you, Namrata, for asking me to comment. You see, I first of all thank Anaga and MOS for making us aware, because you see it is sharing of experiences which, but as soon as I came to know through this group that a lot of cases are happening in pockets, not only in one place but multiple places. So that raised our tentacles, and me and Namrata immediately next day itself we swung into action. And first was the advisory we immediately issued to all the members that these are happening. We communicated by email to everybody that such group of lenses are facing issues. And then we immediately held the next day. It was a Sunday, I remember, and we were at different places, but we on Zoom platform had a huge number of attendees attending, because we wanted some feedback to come so that we can take it forward. So that open forum was held on Sunday, and a lot of advices had come out. Based on that, plus our own observations, we requested all the members to send us those lenses, so that AIOS, because of the huge membership, puts its weight behind, because what was close to my heart was that no member should suffer. You see, whether it is Dr. Anaga or ABC, the patient should not find fault with the doctor when the fault is somewhere else. You see, I never wanted doctor to be unnecessarily dragged into, say, court of law, that meri nazar nahi aayi and all these things, for no fault of theirs. So that was the moot point. I thought I have to initiate all this my years. So we wrote to DCGI, the FDA counterpart in India. We wrote to them that these complaints have come from this and this group, so kindly investigate at your end. The third thing which we did was we collected samples from all the people who had sent, and a lot of people had sent in samples to us. We also sought cooperation from the managing committee of AIOS, that you tell people. And we at AIOS headquarters received quite a number of samples. Anaga also sent samples to us. So we prepared controlled pockets. We didn't label ye Maharashtra ka hai kahan se. So I told them that label 1, 2, 3, 4, 5, 6, and then we had a coding, double coding done, and we already sent these samples. So reports are still awaited. The reason I did this was because I never wanted to be biased against any company, because I'm not going to label a company a blacklisted till the time I have my report from, and these labs which we have chosen are certified labs from DCGI. It's not that any isolated lab we have taken. So these labs are certified labs by the FDA of Government of India. So I think within another few days, by the time we go back from this conference, we'll have a report. And meanwhile, we also wrote to the company concerned also. You see, DCGI, then sampling, then advisory to all the members, Plus the company also, we wrote that you should also, you know, as a part of your responsibility that our members are experiencing, please try to investigate and, you know, stop these lenses also. So one good thing company did was they immediately stopped those hydrophilic batches of lenses, and they in fact withdrew from the market. So as of now, honestly speaking, the report still has to come, and we will get back to all of you with the report.
So, Dr. Rohit Saxena is here. Rohit, I just want to ask you, and I know you are a member in the DCGI group. So, can you just enlighten us that what is the next course of action generally the DCGI takes when a complaint is, you know, lodged to them?
So, as we've discussed earlier also through in AIOS forums, this is a regulatory work that they keep monitoring real life effects of drugs and devices. So, DCGI now has a device monitoring committee also. So, of course, it has been put to them, but they are in the decision making and regulatory part. The monitoring part of side effects and effects of any drug or device is done by PVPI, the pharmacovigilance, which has a material-vigilance component also. And we have also communicated with the material-vigilance to AIOS. I had very recently talked to them. In fact, yesterday they had phoned. We had circulated through the AIOS office the material-vigilance form that needed to be filled. They have received 11 complaints till now, and all of the 11 are actually towards a particular lens or device. As of now, what they have received, they have only received 11, and they have compiled the Excel sheet, and of course we'll be discussing that. But other than that, they were also, when I apprised them that there are a lot more such complaints, they are asking that they may be collected by anyone, anywhere, and they asked me that just collect and label, because if they email, so it's not necessary that you fill that form, because it can be cumbersome, because I told them that like Anaga has 77 cases, somebody has 80 or so, so it may be difficult for a person to fill one form 70 or 80 times. So they said just compile it and give it, and they will directly contact each and every of the concerned ophthalmologists who's had this and get more data so that they can have a comprehensive evaluation. They will then, I've told them, then we will have a meeting with the AIOS office bearers and some concerned doctors, and subsequently they will be sending their recommendations to the CDISCO or the DCGI office.
So, but then what do they do? Do they debar the thing?
So,
or they, because
first,
the
of course,
company is already recalled the product.
Yeah, so first they will ask for evidence. Of course, they are also happy. Anaga was saying that she has got them evaluated, and AIOS also has got them evaluated. So they will be, their process of getting it evaluated has been hastened, because we'll also be giving them reports of our assessment. They will first, of course, ask for the batch recall, and of course will test these on their own as an independent authority. They will increase red flags, and if required, they are supposed to monitor, they may even send their representative to the company to see whether the company is following GCP guidelines, GMP guidelines, good manufacturing practice guidelines, and of course make sure that there are no corners being cut for the manufacture of this process. And they will take samples directly from the industry, from manufacturing side.
So Rohit, as I know that you see, like you said, pharmacovigilance forms you have to fill, and collective mails also we can collect and send. But what was discussed in the morning in the managing committee was a couple of members raised this point that if it is found, there is a big if this endotoxin or monomer content is beyond the permissible level. In couple of reports, one report already is there from Arvind Eye Hospital,
Yes.
one we have submitted, one DCGI may do. Is there going to be some kind of penalization?
Yes, sir, definitely. I mean, they can, the company's license for manufacturing can be revoked if they find that they are
So that is one
not
part.
following
That
GMP
is one
guidelines.
part. Second was any compensation to the members who have suffered.
So that is, because I don't think even, actually the DCGI is not empowered probably to make that. So that's not something which they, I don't know actually, frankly, I've never, I don't know, but knowing their mandate, I'm not sure whether they can
No,
do that.
but because on such a large scale, I think we've never, even in the history of AIOS, represented so overwhelmingly to the pharmacovigilance department or to DCGI. Most of us, in fact, now thanks to the WhatsApp group where we all can communicate our problems and can form groups, but most of us, in fact, I mean, if isolated cases are there with us, we probably would think it's intense reaction or whatever and would not bother. And more so because the prognosis for these cases have not been bad. But that doesn't absolve anybody of the responsibility of the fact that there is a problem.
So, like I said, the company can be fined and the company's license can be revoked as by the action by the DCGI. But regarding compensation, I mean, I doubt, because DCGI I don't think has the power to. So,
Sir, in
yeah, of
case
course,
of
that would be totally different.
in case of knee transplants, like there was a case with the Johnson knee implants. So in that case, compensation was awarded.
By the courts. So that's
By the
what the
court.
whole thing is. In fact, actually, the process for that was different. That went legal route. Patients had filed in
So
the court.
patients had to file,
Yes.
not the doctors and not...
Yes. So, I mean, anybody can file. It's a question of compensation against what are you asking for. So you will have to, show
No,
damages for which you will
those
be
were
taken.
implants which are not up to the mark, and
Yeah.
they recalled the product, and then the courts they allowed compensation for the patients.
Yeah. So,
So
yeah, patients
if,
were given.
if at a AIOS level we follow it that way, maybe we can get the company to compensate for to the patients directly or to the surgeons.
Are there any comments or questions on this aspect of TASS outbreak? We have some unofficial reports already which says that out of 9 lenses that were tested, 5 did have endotoxins.
So
But they are not from approved labs by the DCGI, so we are awaiting. And there is a difference. There are some labs which are approved for drugs. There are
Yeah.
some labs which are approved for devices. So you have to find out a lab which is approved for devices. In Delhi, there was only one. There was another one which was listed, which has been closed. So we are awaiting the results from there.
So, the end product that we've been discussing also, in the morning also I was discussing with Anava, what is our best outcomes that we are expecting out of this? So, two things which I felt has the positive side of this would be, one, that through AIOS and under the aegis of AIOS, we now have a very strong network where people have a place to report, and I think the AIOS should advertise this, that this is the first time as a group we have encountered a problem, and as ma'am is saying that, up till now we were kind of blaming ourselves or reviewing ourselves. We must list it out so that we start accepting that, it should not be defensive all the time. There are other people who are concerned, who are at fault.
No, I think, yeah.
And the second thing is the good outcome, that if this is taken to its conclusion and whoever is responsible, company, whatever, then, there is some regulatory intervention that will force Indian manufacturers to
think
improve
about
and make sure that they follow GMP guidelines. Because right now we all know that all these things are a little lax and everybody cuts corners. So I think the best outcome would be for that. I feel, and I think AIOS is doing a wonderful job to pursue and make sure that clinical practice becomes safer for all of us.
Thank you, Rohit.
Many
Yes.
IOLOPC
Yes.
Can you tell me, ma'am, which material?
So generally
our
they are
company-
all hydrophilic intraocular lenses only. They are not hydrophobic, and they are across all companies. So if you use hydrophilic acrylic lenses, then chances of IOL opacification are more.
Thank you.
Okay, thank you everyone. Thank you for being here.